Welcome all to the today's live session. So today's session is on maternal medicine. We begin with our quote, Master MRCOG with concept-oriented clarity. So we have total 6 talks for the discussion. The first talk is constipation in pregnancy. So this constipation in pregnancy, there can be one SBA on this particular talk. If you see the epidemiology of this particular constipation, it is around 11 to 38%. So roughly around 40% patients have the constipation. We know that it is a very common condition during the pregnancy. It is more common in the first and second trimester, around 35 to 39%. It is relatively less in the third trimester, around 21%, and postpartum around 17%. Okay, so if you see the pathophysiology of the constipation, it is mainly hormonal etiology. We know that progesterone is a predominant hormone which reduces the gut motility, causing the smooth muscle relaxation. Then motilin hormone level is reduced, so that decreases the peristalsis. Somatostatin will also reduce the GI motility, and it is the relaxin hormone which is present that causes hypomotility of the gut. Now, there are certain changes which are happening in the fluid and electrolyte changes, such as there is an increase in the renin, angiotensin, aldosterone system that will lead to the increased absorption of the sodium and water, and that will lead to the formation of the dry, hard stools. Now, there are certain mechanical and lifestyle factors such as reduced intestinal movement, low fiber intake, reduced fluid intake, iron, which is known to cause constipation, and postpartum pain, maybe because of episiotomy or fissure. These are the contributory factors for the constipation. Now, how this constipation is classified? There are two types. One is a primary, also called as functional, and second is another is a secondary. Okay, so in primary there is no underlying pathology, while in secondary it is due to either disease or the drugs. And to say that it is a functional constipation, there are criteria which is called as a Rome 3 criteria that we will see subsequently. Now, what are the secondary causes for the constipation? It may be GI related, such as anal fissure, stricture, malignancy, metabolic, such as hypothyroidism, hypercalcemia, neurological disorders, and iron opioids. So these are the drug induced also. So what are these Rome criteria? There are 3 Rome criteria which you see in this particular table. Okay, so these 3 criteria are the patient. In first criteria, there are 6 subtypes they have given. So at least 2 of these subtypes should be present. 2 or more should be present from the first criteria. That is, there is a straining for more than 25% of defecation. There are hard stools for more than 25% of defecation. There is incomplete evacuation in more than 25% of defecation. There is an anorectal blockage or sensation of the anorectal blockage in around 25% or more defecations. And patient may require manual removal of the fecal matter that is present in more than 25% of cases. Or there are less than 3 defecations per week. At least 2 should be present out of these 6. Okay, and second criteria is loose stools are rarely present without the use of laxative. And third criteria is that there is insufficient criteria for labeling this as a IBS. So there are no sufficient criteria to say that there is a irritable bowel syndrome. So there is no criteria for there are no criteria for the irritable bowel syndrome. There are no loose stools without the use of laxatives, and there is either straining, hard stools, or incomplete evacuation, or an electrical blockage, or manual removal in more than 25% of cases, or minimum 25% of cases, and less than 3 defecations. So if these 3 criteria are present, in that particular case, we say that it is a functional constipation. Okay, so what are the complications? There can be fecal impaction, urinary retention, rectal bleeding, rectal prolapse can happen, and pudendal nerve can get damaged, leading to the pelvic floor weakness. Okay. So what are the clinical features? There will be dry, hard stools. There will be history of straining, incomplete evacuation, digital evacuation, painful defecation. These will be the complaints of the patient. Then what are the red flag features which require urgent referral? If there is any change in the bowel habit for more than 6 weeks, rectal bleeding, family history of colorectal cancer, or known case of irritable bowel disease, then we will refer these cases. So coming to the management. The first line management is a non-pharmacological or lifestyle management. That is, increase in the dietary fiber, bran, wheat fiber, increase fluid intake, lifestyle advice will be given, and reassurance to the patient. Okay. Then second line, is the use of laxatives. Then in the laxatives, there are various types. The bulk forming is the first choice. The first choice of the laxative is the bulk forming. It is a fiber agent such as isabgula husk, methylcellulose, sterculia. These are the bulk forming laxatives. They are safe in pregnancy. They are not absorbed. They are slow in onset, but they are contraindicated if there is a fecal impaction. Second category is the osmotic laxative. So lactulose, but it is to be avoided in diabetes. The commonly used is PEG, also called as macrogol, or it is a basically it contains the polyethylene glycol. That is the drug of choice in the osmotic category. Next is a magnesium salts that is to be used with caution. So mechanism is that they increase the osmotic load in leading to increase water absorption, and there is an increase in the peristalsis. Side effects are the bloating, flatulence, and electrolyte imbalance. Okay. So PEG, that is polyethylene glycol, is the treatment of choice for chronic constipation in pregnancy. But the first line will be the non-pharmacological measures along with the uh, bulk farming can also be used, but PEG is one of the preferred nowadays. Okay. Then stimulant laxatives are the Senna and Bisacodyl. Senna is safe. It has got a minimal risk. Bisacodyl is also safe. It has got a minimal absorption. They are more effective than the bulk, but they are to be used with caution in the third trimester because there is a possibility of the uterine contractions. Okay. Then coming to the stool softener, that is a docusate sodium. This is to be used in low doses. There is a risk of neonatal hypomagnesemia. It is excreted in the breast milk also. Then rectal therapy by use of glycerin suppository, especially if there is a fecal impaction, enema, but it has got a limited safety data. Okay. So drugs which are to be avoided in these patients having constipation are anticholinergics, antispasmodics, then calpopride, calopride and linaclotide. These drugs are to be avoided. Okay. Newer drugs, they are to be avoided, and these we will not go into the details. Then withdrawal of laxative, it should be gradually. You have to taper it. Stop stimulant first. It may take months. Relapse is common. There are special situations such as postpartum constipation. It may be because of pain, hemorrhoid, or hormonal changes. So take-home message is that progesterone reduces the gut motility. There is a aldosterone renin angiotensin activity is increased. So aldosterone will cause increased water absorption and leading to the hard stool. Most common in early pregnancy. Rome 3 criteria are used for the diagnosis of functional constipation. First line is a dietary fiber plus fluid. Safest laxative is a bulk forming agents. Best drug is a PEG. Then drugs to be avoided are the anticholinergics and procalpopride. Then stimulants, we have to be cautious in the third trimester, and if there are red flags, we have to think about the malignancy. Okay. So lifestyle, fiber and fluid is the preferred bulk forming laxative. Then osmotic PEG, you should remember. Stimulant if required. Okay. But when stopping, you will stop the stimulant first. Then suppository enema if there is an impaction, and refer if there are red flags. Doctor, can you read the SBAs? Doctor? I cannot hear now.
Hello,
Ah, yes,
hello.
yes, please. Yes, please.
Yes, sir. A 26-year-old pregnant woman presents with constipation. What is the most likely pathophysiological cause? A. Increased motilin. B. Increased progesterone. C. Decreased aldosterone. D. Increased peristalsis. E. Increased gastric emptying. So it is increased progesterone. B.
Yeah. So option is B, increased progesterone level. That is one of the cause for the constipation in the pregnancy. So progesterone is a smooth muscle relaxation, causes smooth muscle relaxation. So decreased gut motility leading to constipation. Next question, doctor.
Yes, sir. Which laxative is first-line pharmacological therapy in pregnancy? A. Senna, B. Bisacodyl, C. Ispergilla husk, D. Lactulose, E. Docusate. It is C. Ispergilla husk, bulk
Isabgula
forming
husk, that
agent,
is a preferred one. Okay, so bulk forming agents, that is the safest and first line.
first line.
Mm, yeah, next.
Which drug is considered treatment of choice for chronic constipation in pregnancy? A. Lactulose, B. Senna, E. Polyethylene glycol, D. Docusate, E. Procalopride. It is C. Polyethylene glycol,
Yes,
PEG.
PEG is the preferred for chronic constipation in pregnancy. Okay. Next.
Yes. A pregnant woman presents with fecal impaction. What is contraindicated? A. PEG, B. Lactulose, C. Isabugula husk, D. Glycerine suppository, and E. Bisacodyl. It will be C. Ispagula husk.
Yes, isabgula husk is contraindicated if there is a fecal impaction. So bulk laxative will
Is-
worsen the obstruction. So they are
So they're
contraindicated. That
contraindicated.
though they are first choice, you have to remember it is contraindicated if there is a obstruction. Okay.
Yes, sir.
Next.
Which drug should be avoided in pregnancy due to limited safety data? A. PEG, B. Senna, C. Prucalopride, D. Bisacodyl, E. Isabugula. It will be C. Prucalopride.
Yes. Yeah. It is a 5-HT4 antagonist not recommended during the pregnancy. Next.
A woman develops bloating and flatulence after starting treatment. Which drug is most likely responsible? A. Senna, B. PEG, C. Lactulose, D. Bisacodyl, E. Doxosate. It is C. Lactulose.
Yes, lactulose is known to cause, it causes fermentation of the sugar,
Bloating.
gas and bloating. Doctor, next.
Which statement about stimulant laxatives in pregnancy is correct? A. It is contraindicated in all trimesters. B. It is safe but avoid in third trimester. C. Causes teratogenicity. D. First line therapy. E. Not effective. B. It is safe but to be avoided in third trimester.
Yes, there is a possibility of the increased uterine contraction. So risk of uterine contraction is present, though it is theoretical. So one has to be cautious. Next.
Which feature is included in Rome 3 criteria? A. Daily bowel movement. B. Diarrhea. C. Decrease less than 3 bowel movements per week. D. Weight loss. And E. Vomiting, which
We
is
have discussed
included
Rome
in.
3 criteria.
Yes, sir. It will be daily bowel movement.
No, it is less than 3 bowel movements per week.
Okay.
Okay. Okay,
Yes,
so
sir.
hardly there are any loose stools without use of constipation. There are no criterias to label this as a irritable bowel syndrome, and there are 6 symptoms out of which
Out
at
of
least
which two should be.
two should be present. Okay, those are uh, we have discussed that there is a constipation, hard stool. Okay, there may be manual removal. Okay, so anorectal obstruction. So these are the symptoms in more than 25% of defecations. Okay, so at least 2 out of that and other 2. Okay, next.
A pregnant woman with constipation has rectal bleeding and altered bowel habits for 2 months. What is the next step? A. Start PEG. B. Increase fiber. C. Reassure. D. Urgent referral. And E. Start Senna. Rectal bleeding needs urgent referral. D.
Yes, and bowel habit alteration is more than 6 weeks, and there is a rectal bleeding also. So she will require urgent referral to rule out malignancy. Next.
Which mechanism explains hard stool in pregnancy? A. Increased gut secretion. B. Increased water absorption. Decreased sodium absorption. D. Increased motility. E. Increased bile secretion. It is because of increased water absorption due to increased aldosterone activity.
Yes. So B, aldosterone will increase the water absorption, leading to the dry stools. So this is the quick look. PEG, polyethylene glycol. First line drug is the bulk laxatives. Best drug is the PEG. Avoid prucalopride. Red flag is a red bleeding. Rectal bleeding, and progesterone will reduce the motility, aldosterone will increase the water absorption, and bulk laxatives are contraindicated if there is a fecal impaction. So that finishes our talk on constipation in pregnancy.